For this special webinar Wednesday, we are focusing on an emerging treatment for MS, CAR T therapy. This webinar series is brought to you by Can Do Multiple Sclerosis. My name is Krista Sipp. I'm the Director of Programs here at Can Do MS. I want to take a moment to thank our sponsors this evening. So a special thank you to Bristol Myers Squibb and Kyverna. So now I am very excited to welcome our speaker this evening. Tonight, we are lucky to welcome neurologist and leading researcher, Dr. Gregory Wu. Dr. Wu is a professor of neurology, as well as a professor of pathology and immunology at Washington University in St. Louis. Dr. Wu's research focuses on unraveling the complex interactions between the nervous system and the immune system. So today, Dr. Wu is going to share insights specifically on CAR T therapy as a promising avenue for future treatment for MS. So with that, welcome, Dr. Wu. Thank you so much for being here.
Thank you so much. I appreciate the opportunity to share some of my ideas about CAR T cells and to be part of, I think, the engagement through this group that links people with a strong interest in understanding what potential future therapies could emerge for MS and related diseases. Okay, so this is my outline. I'd really like to highlight what the need is in MS and related diseases. Really walk through a little bit of what gaps in therapeutic options are available for MS patients. Sort of, I think, try to highlight the underlying pathology of MS that has been unaddressed for many, many years. And then sort of speak quickly to the idea that our immune system in multiple sclerosis likely has a tremendous amount of specificity that can be targeted, leaving room for a lot of different choices for therapy in the future. Okay, let me see. I can fix my audio. I've been requested to speak a little louder, so give me 1 second, and I will crank up my input volume. How's that? That should be a little better. Okay. Then I'd like to move into the concept of CAR T cells and describe what they are, and hopefully be able to really understand the basis or the basics of this new therapy for autoimmunity and multiple sclerosis. I'd like to really discuss data to date, but unfortunately, there's really more, I don't know, sort of to be desired at this point, because this is such an early time in the application of CAR T cell therapy for multiple sclerosis. There are, of course, risks and benefits to new therapies or any therapy for that matter. So briefly, I have a slide that just outlines some of the advantages and disadvantages of CAR T cells. Okay, so with that in mind, I'll just briefly state that we may be interrupted by a barking dog. I apologize about that, but we'll do the best we can to work around that. Okay, first thing here, what is the problem for multiple sclerosis? What's the need? What is our current situation in MS? This is not intended to be a complicated slide. It's really actually oversimplified, but hopefully the concept comes through, and many of you will likely understand what this represents. On the x-axis is time, and this scale is not day to day or hour to hour. Rather, it's week to week, month to month, or even year to year. That's the time scale that we're graphing here on the x-axis. On the y-axis is graphed disability. So in MS, we see changes in disability, emergence of problems such as walking difficulty, vision changes, the sort of accumulation of some problem that we would refer to as a relapse or an exacerbation or a flare. This is often coincident. It should be coincident, actually, with detection of an area of injury within the central nervous system. And MRI plays a really key role in understanding what changes in the nervous system occur to produce this disability. I've sort of tried to indicate here that there are more changes in the MRI that often are witnessed relative to the disability that can emerge for an MS patient. This doesn't suit everybody. I know this doesn't fit everyone with multiple sclerosis, but I want to make sure that we sort of get the idea that there's a clinical presentation and an MRI presentation, and disability is something that we're trying to control with disease-modifying therapies, or DMTs. That's an abbreviation for disease-modifying therapy. So this is an example of somebody who comes in to see a patient, to see a neurologist. This is a patient here. And at this point, we could make a diagnosis of multiple sclerosis based on this evidence and other evidence and so many different tests that you've all been through. And we choose a disease-modifying therapy. That disease-modifying therapy intervention should theoretically maintain a baseline, that a patient should no longer exhibit MRI changes or disease activity. This line should be relatively flat. We do feel as a field, as a collection of scientists and clinicians, that the ambition to keep people at this level of disability once a disease-modifying therapy is instituted is a reality. Many of the therapies that we have are highly effective this way. One example of that is a set of drugs that deplete B cells, a lymphocyte known as B as in boy cells. B cell depleting therapies as a DMT are highly effective. But even though those drugs that deplete B cells from the circulation have shown a very striking effect in reducing relapses, we still have detected that many of our patients will develop a progressive form of disease. This progressive form of disease was originally thought to occur as a result of repeated insults that were detected by relapses or MRI changes. In spite of the fact that many patients respond well to current disease-modifying therapies and exhibit no more relapses or MRI changes, those same individuals may go on to develop an unrelenting accumulation of disability without remission that we would term progressive multiple sclerosis. That there's a disease-modifying therapy that's instituted, and in spite of the fact that that can vary, significantly abrogate relapses or MRI activity, that many patients will still go on to develop a progressive course of accumulating disability. Unrelenting disability accumulation is a hallmark of progressive disease. So it's recognized now that progression independent of relapse activity, or PIRA, is something that could help us understand why progressive MS occurs in the first place. So people now have turned their attention to the idea that earlier in the disease, there may be clues as to why people have progressive MS. For example, this MRI on the left side of the screen is supposed to indicate paramagnetic rim lesions. In this chronic lesion that's seen in the middle, there are certain immune cells that might pick up more iron and indicate that this lesion actually is more likely to contribute to additional damage, even though on a regular MRI, this lesion would look unchanged. And the idea here is that these inflammatory cells within the brain, not immune cells that are coming from outside the brain, but rather our resident immune cells, contribute to the ongoing damage to nerves and myelin, in spite of having no change in the size or sort of primitive appearance on MRI based on traditional metrics. So this is PIRA, progression independent of relapse. And it's just this idea that maybe there's a clue to how to target that based on our imaging and other pathology studies of MS patients. Okay. As I mentioned too, there may be chronic lesions that exhibit those features. But what are other features of more established multiple sclerosis that might contribute to progressive multiple sclerosis? This is a huge need in our field. I suspect that many of you attending tonight would recognize that there are very few options for patients who have progressive MS. The features that underlie multiple sclerosis that's established and more in line with a chronic disease state would include those changes that we see in the lesions with the paramagnetic rim seen on MRI, with this slow expansion of an active lesion. And then on top of that, accumulating immune cells within the layer around the brain and spinal cord called the meninges. This picture here on the right is supposed to be depicting the skull on the top, and then this border between the skull and the brain on the bottom side of the picture that contains a layer of tissue as well as spinal fluid that circulates around the brain and spinal cord that ends up hosting immune cells, aggregating in a way that might contribute to damage that's underlying that collection of immune cells. Okay, and so this is actually tucked away in the central nervous system. For example, in this picture, there's a real close collection of immune cells sitting in the meninges right over the brain. Okay, so in this scenario and in the idea that there are these chronic lesions that just continue to smolder or sort of in a low level continue to contribute to damage to the nervous system, we don't have a real good way to attack that with our disease-modifying therapies. That's what we're at right now. So that's the need. And that's where many of the investigations and current therapies are trying to intercede and sort of intervene. One way in which that could be done, conceivably, is using a cell therapy, using an immune cell as a quote unquote living drug. CAR T cells, the CAR part stands for chimeric antigen receptor, and the T cell is the fact that this engineered chimeric antigen receptor is placed into an immune cell called a T cell. T cells are part of our immune system. In fact, we think that some T cells may be driving MS disease. Well, going back a step, it turns out that T cells serve a very, very important function. Without them, we cannot fight off infections or other injuries. In fact, removal of the CD4 T cell population through the HIV infection leading to AIDS is obviously a very bad thing and has really severe, implications, right? So our T cells are important. In this case, and the reason for that is because the T cells serve a very specific purpose. They can fight off infections as one example. And a major theme for this is the idea that T cells do a good job in our body. In MS, they may be responsible in part due to our investigations in animal models and other studies and even therapeutics. They may be a real key ingredient in driving MS disease, but in general, T cells are beneficial. Now, how do we make a T cell see what we want it to see in order to kill? The T cell has its own receptor. Each T cell could carry a unique receptor, one that recognizes flu, for example, one that recognizes a pneumonia bacteria, one that recognizes even a cancer target, okay? The T cells in our own bodies already have a wide repertoire of diverse receptors that tell it what to target in order to recognize that and kill it. In a CAR T cell, scientists have managed to engineer the outside of the receptor to recognize what we want it to see. And once it sees that target specifically, it triggers a signal inside that leads to killing. So the chimera, the two parts, are the external part that says this is what the T cell should see and target, and the inside component of the receptor of this construct is to say, go ahead, initiate the killing signal. So it's very specific based on the outside, and it's highly potent based on the inside part of this molecule. Okay, so CAR T cells are really, really great. Traditionally, CAR T cells use this outer part called the single chain variable fragment that we could use and pick out to say this T cell needs to see a molecule that, for example, exists only on B cells, just like that category of disease-modifying therapies I alluded to earlier. Okay, we know that B cell depletion therapy is highly effective for relapsing MS, but it fails to control progressive MS. Why in the world will we create a CAR T cell that sees the exact same target? The reason is because these T cells, as a living drug, as part of our immune system, would be able to travel to the parts of the body that are most affected in progressive disease. For example, this meningeal space, for example. So the CAR T cell seems to have advantages being part of our immune system. And if we could just quickly change our immune system to see the right target, then it might be beneficial to patients with multiple sclerosis. Okay, let me clarify chimeric. Chimera or chimeric comes from this Greek myth of an animal that has a head of a, I believe it was a, I don't know, a hawk, and the body of a lion. I might have screwed that up. I'm sorry if I didn't get it exactly right. But it's really the idea that there is one entity that shares two separate features. So chimera here is the two parts, the outer part that's glued onto the inner part, which is different. This outer part is actually just the part that recognizes a specific target, but it's not a T cell receptor. It's actually an antibody fragment. So it's something that the T cell would never normally have. The inside is a signaling component that the receptor would normally have, but we've glued it to something on the outside that's different, and therefore it's a chimera. These kinds of CAR T cells have been developed mainly for cancer. The original intention by the scientists who developed CAR T cells was to use a living immune cell in our body to travel to cancer targets and kill them. Okay? How does this work? Patients will typically give their own T cells. Those T cells are then put in outside of the body into a culture system, isolated, and then given this construct, this CAR construct or this CAR molecule. It's usually delivered by a little virus. This is packaged in a virus. And then the T cells from this patient would uptake that and start making this ideal receptor chimeric signaling molecule. Once that's expanded so you can get enough of these cells, it's delivered back into the patient. This is the version of CAR T cells that we would call autologous or self. They come from self. In other versions that are being developed currently and tested, there's something called off-the-shelf CAR T cells, where the T cells that have this construct do not come from the patient themselves, but from a universal pool of donors or one donor that becomes capable of being delivered to any number of different patients. Off the shelf versus autologous, and their advantages and disadvantages of both. This is a typical type of strategy that's been proposed for multiple sclerosis and other autoimmune diseases, okay? By the way, this is not super duper simple. We can't just take your T cells out today, do this process and culture them, and in the same day give them back to the patient. This takes days and maybe weeks in order to optimize for an individual. The other thing that I'd like to point out is that once you've cultured these cells and you have a bunch of them that you want to deliver back into the patient, most of the time we realize that these T cells do not have room to go back into the individual. Our bloodstream contains a very nice, even, consistent level of white blood cells, and these T cells are a white blood cell subset. So shoving more in might not be feasible because the body says that we don't have room for that. We don't need that. And they're not going to survive because of the way in which we already have limited our amount of white blood cells in our body. So to deliver these back to the patient, most often they will receive something called lymphodepleting chemotherapy. These are highly potent immunosuppressive drugs that actually are designed to remove lymphocytes from the bloodstream. In autoimmunity, these were some of the very first drugs attempted to use as therapeutics to treat patients. So, in other words, there's a combination of therapies that are mixed in with CAR T cells that are sort of dismissed or not really spoken directly about, and I want everybody to be aware of that, okay? Here's an example of ongoing trials using these CAR T cells. To me, this slide represents a tremendous amount of promise, a lot of excitement. I know that patients whom I've spoken with have really indicated that, in fact, this is a very dispiriting or kind of depressing slide because we're so early on. These are phase ones, they're open label. Basically, it's just the entry level of clinical trials that are being undertaken. Nevertheless, this process is moving fast. I am aware of many, or I should say, I am aware of trials that have of companies that have completed phase 2 trials already. And here is an example of that was reported this year. This was a really exciting thing to demonstrate that the field could be ready for these CAR T cells. Let me walk through this. It's essentially a case report, which mostly scientists balk at as, trying to represent really stringent, rigorous research. It's really important in this case because of three things. Number one, the application of CAR T cells to multiple sclerosis, what I've been talking about this entire time. Number two, the fact that these two individual patients had progressive disease. One of them has primary progressive, that's case number 2. The other was relapsing remitting initially, then developed progressive disability a few years prior to being treated with the CAR T cells. And I think for our field at the moment, the folks in my shoes who've read this paper, number 3 is likely to be at the top of the priority list, which is the fact that this was a safe treatment for these two patients. So on the left here of these graphs for these two individuals was the clinical outcomes. And on the right, there were two things being graphed. In green or teal, whatever this sort of lighter color is, that's the amount of disability that's measured clinically. You can see here that there was a little bit of a spike for this individual, and they returned to where they started at on a scale of 0 to 10. And in this individual that was only really followed for about a month, there was no change in disability as marked here in this line, EDSS. The other thing that was followed was, in this case, it was T cells, I believe, in the blood. It was also measured in the spinal fluid and showed a nice abundance over time. That these CAR T cells, the therapy, the treatment, persisted. They didn't get killed off. They didn't go away. They are still there and present. Okay, super exciting. Let me quickly touch on this, though. I have a lot of hope for CAR T cells, but as many of my colleagues would agree, I'm sure, we don't know how well they would work, and so weighing pros and cons is very difficult at this time. The experiments need to be done. As a scientist, but also as a clinician, we just don't know if these CAR T cells are going to be a great thing or maybe not so great of a thing. Here's what would be great. If the cells actually followed the immune expectation, that they go to the place of the brain where these antibodies and other therapeutic agents cannot access, and that they actually do their job well in reducing some immune cell population that would be driving this progression. How long would this therapy last? In the two cases I showed you, the second case was only followed for a month before we received the report on that patient. We need to know if this therapy will have a long-term effect. However, I do expect, and many people expect, that the ability for these immune cells to persist is going to be high. It's going to be a long-term thing, and they should be very, very durable. Once they're there, they can continue to do their effect without having to be redosed. In one case, currently with a therapy that's currently FDA approved, you go back every 6 months, which doesn't seem like that long, but that's indefinite, every 6 months. Here we don't know, we expect them to be highly durable and long acting. Yes, good question. How do we remove them? That's over here. We don't know if we can actually get rid of these cells. There are ways in which you can engineer them to be deleted if entirely needed. And some people have made CAR T cells for other purposes where there's a kill switch that you give a pill, the cells die immediately. But nevertheless, that's a downside potentially. The other possibilities are the flexibility. In the labs that exist here and around the world, we can make these CAR constructs, right? The receptor inside and outside stuff super easily. Those are things that we can make and design and imagine and create very flexibly. So that's a really key thing. And they could be personalized. One individual could get one kind of CAR, they could get a specialized CAR. And I think that's a real boon to CAR T cell therapy, that it could eventually be something that we treat an individual with in a personalized way. There's ongoing innovation, and this is driven mainly by the cancer field. I got to be honest, okay? This cancer innovation about how we create new generations of CARs, optimizing them and making them better, are going to be applicable to the multiple sclerosis arena for sure. Cons: this is not an easy drug to get a hold of. This is not something that you could go to your local doctor and ask for. It's definitely something that needs to be, at least in the current situation, accessed through a more specialized, likely tertiary center. We still don't know how well they work, as I mentioned, and there are side effects. ICANS and CRS, these are two side effects that are well recognized from the cancer world. ICANS stands for Immune Effector Cell Associated Neurotoxicity Syndrome. It can be fatal. CRS stands for Cytokine Release Syndrome. Again, a potentially fatal outcome. These are changes that we really don't understand. And I'd point out that unlike cytokine release syndrome, where the body systemically reacts to some increase in inflammation, ICANS is largely neurologic in effect. So now we're taking a neurologic disease and asking to avoid neurologic complications, which just is really unclear. Again, that case report of 2 individuals receiving a CAR T cell without the major side effects of these two is very promising, but it's a possible downside. And then just in the last year, it's been recognized that CAR T cell therapy for patients with cancer, not autoimmunity, but cancer, may result in some increased risk of developing a different type of cancer. So it's just something that we, instead of saying is so cool because it's new and we're innovating, kind of as a downside because we don't have a tremendous amount of experience even yet in the cancer world, but for sure within the multiple sclerosis or autoimmunity arena. Okay, I want to talk about one more thing. This is the area of interest that I have specifically in my own research, and that is targeting these T on the left and B on the right cells. These are immune cells we think are driving the inflammation in multiple sclerosis specifically. And they come in different flavors, like I talked about. Each one shown here is unique because the receptor sees something different. Same thing on the right. The receptors are different. This blue B cell is going to recognize something different than the yellow one. This is to just indicate cartoon-wise the diversity of the immune response that we have, and we need this, right? Now, instead of having 6 different immune cells, T and B cells, there are millions upon millions of different diverse specificities to these, but only some of them are thought to be triggering and driving multiple sclerosis. I've chosen just here an example of MOG-specific T cells. We don't know if these are driving MS, but they certainly would likely be expected to drive a related disease called MOG antibody disease. MOG stands for myelin oligodendrocyte glycoprotein. So just out of this millions upon millions of diverse T cells or B cells, we only have a few that recognize a particular target that may be responsible for MS. I'm calling it MOG here. We don't really know what that is, but we do expect that there's some specificities. Now, those are the ones we care about. And we can design cars, theoretically, to only instruct the killing to these specific T or B cells. Pretty cool. That would mean that instead of wholesale eliminating all of these populations, and the examples I've been giving so far, it's on the right, we would get rid of all of the B cells. Now we're just removing the slice of the immune response that's driving inflammation and keeping the remainder of the immune response that we need to fight off infections so that we're less immunosuppressed. Okay. That's what I have to talk about in terms of the potential for CAR T cells. I really do hope that I've presented information that's useful for you listening today about this emerging therapy that we're very excited about in the field of MS. Thank you.
So now I am excited to have a little Q&A session with you as well, Dr. Wu. We have had multiple people ask questions about potential age limits for this treatment, these trials. Is there a target age group that you are looking at for treatment for people that would receive this treatment? That would be ideal.
Right. I'd like to just spend a couple minutes on this question. It's a really good one. The idea here is that traditionally our trials have ignored older patients. Many times we're seeing results from trials that are exciting, but they have only included patients to the age of 55 or sometimes even 50. That's unfair in large part because we know that there are many people living with multiple sclerosis who are older. Again, going back to the initial sort of need that we have in our field, I hope to have highlighted the fact that it is the more chronic stage of MS that's associated with progressive multiple sclerosis, and that's a huge need. Those patients tend to be older. So I really respect the question because it emphasizes the big gap in therapeutic options that patients who are older have, and clinicians are limited too. Let me say two things about that. Number one, as it's presented as the sort of intended target of creating a therapy for progressive MS and chronic MS, our intention would not be to exclude older patients. The second thing is that in the cancer world, again, we're deriving a lot of experience for patients who have undergone CAR T cell therapy for cancer. Older patients have done, for the most part, just as well. They don't experience a tremendously greater burden of side effects. They do not seem to respond differently to CAR T cell therapies. So the idea amongst the field of clinicians is the fact that we have now the potential to use a therapy not specifically designed for older individuals, but not excluding older individuals. And so I'd really be comfortable saying this is appropriate for people who have MS and have had established disease for some time.
Thank you very much. I appreciate that. Hopefully that answers everyone's questions. I know we had a number about age. Another thing that we've had a few questions on is comorbid health conditions. So if someone has a secondary condition of any sort, diabetes, thyroid disease, heart disease, Crohn's, et cetera, would this kind of treatment be a concern for anyone with those kind of conditions?
For this one, I'm afraid I can't be as definitive as the last question. It's a fair question. It's an important one. No matter the therapy that you and your physician have decided on, there is that risk side of the equation. That risk goes up if you have comorbidities. As far as I'm aware, however, in the CAR T cell world, we don't see a specific consequence to cardiovascular disease, diabetes, or these other things that are more likely to be present in older individuals or those who have just different backgrounds. That being said, I really want to emphasize we don't know enough. We need to do the trials and experiments to see whether those individuals with MS and, for example, coincident diabetes or thyroid disease, et cetera, would have different outcomes. My expectation is that that's not the case, that we can't single out one or multiple comorbidities, but I don't know that for sure.
Okay, that's fair. I think it's unique to everyone, you know. So What has changed in what we know now about MS that has led to CAR T cell therapy being even considered and being an option?
I think there's a lot to be sort of trumpeting about that. One would be what sort of indicated early on that I sort of focused on, which is, oh my gosh, there is a type of MS that we can't even prevent, let alone treat. That's this sort of progression. And not only that, we suspect we know some of the key immunologic drivers of that progression, whether it's independent of relapse activity or not. So what I would say is the main thing in MS that we're taking and using as a rationale for developing these CAR T cells is that compartmental inflammation. That is, I sort of tried to indicate that the meninges is a certain sort of target that many antibodies or other therapies can't reach. And that also within the brain, there are special immune cells that are driving disease that may also be influencing progression and other features that we just haven't been able to touch with our current treatments. That being said, I think there are a couple other things in MS that we really do suspect may be uniquely amenable to CAR T cell therapy. Again, repeated administration of drugs. Many of my patients who I started treating decades ago do not want to continue with the type of therapy they've been on, whether it's a weekly or 3 times a week therapy or even a daily pill. We're moving away from that in the world of autoimmunity, where we may be able to give a drug, a living drug, a cellular therapy, a bone marrow transplant, whatever it may be, that sort of interferes and then sets the table as a durable response long term. I know that's not unique to multiple sclerosis, but I certainly have had that experience as a clinician, dealing with the frustration of an ongoing therapy that just seems like it's never ending. And the last thing I'd say about this unique kind of feature of multiple sclerosis is we know, I think, that we're only at the tip of the iceberg. I would like to just kind of go back to the concept that I alluded to earlier, which is that many of our therapies inform us about what the causes or underlying issues of MS really are. And I don't want to pick on any particular drug category, but the new drugs that are coming or the old ones that have been around, we've learned not just, oh, this is how well it should work and this is the type of patient that we could use it on, but more about, wait a second, this means that this aspect of the immune system is really involved in MS. Migration of immune cells into the brain and spinal cord is really important. We know that, at least for relapsing disease. And drugs that prevent that migration are highly effective in treating relapsing disease, for example. So I think that this is unique to MS in the sense of like we're reverse engineering. CAR T cells come into play. We may be able to learn even more about MS and how we can treat it even better.
Wow, just fascinating. Thank you. So I want to talk a little bit about the treatment and potential side effects.
Okay.
People are curious about potential side effects that you could experience if you did go down the route of this treatment, and if there's any impact on other aspects of health too. So
Okay.
kind of went
Great.
hand in hand a little bit.
Yeah. So I think I touched on that a little bit in my risks and benefits or pros and cons slide. Let me just reiterate a few things. One is that there are two known categories of neurologic, or excuse me, of side effects to CAR T cells. One, ICANS, two, CRS. I'll be a little more specific with ICANS. ICANS, or this immune effector cell associated neurotoxicity syndrome, typically happens a few days after the infusion, can cause swelling in the brain, bleeding even in the brain, seizures, confusion, loss of cognitive function like language function. These are real hits to the nervous system. Now, they're reversible theoretically, and we do believe they're actually something that we can treat or predict at least. Same as cytokine release syndrome. So this is where patients might have swelling, temperature elevations, a lot of what we would associate with just inflammation in general, that's systemic. That for sure can be treated with steroids and other very targeted immune modulating disease therapy drugs. So I think that the side effect profile of that is highlighted by the two individuals that were reported in the case report that I mentioned. the person that had a transient elevation in their disability score, that little worsening hump, was likely, as reported by those physicians treating that individual with CAR T cells, driven in part by what we refer to as UTOF's phenomenon. Not new damage in the nervous system, but the old damage kind of rearing its head. Many patients with MS, for example, when their body temperature goes up, feel worse, have more symptoms that emerge. In this case, that may have been the case. And then lastly, just kind of getting at the idea, could this CAR T cell affect other organs and whatnot? I think I would refer back to my other answer. We're not entirely sure, but from the cancer world, it doesn't seem like these CAR T cells are going to go off and do something specific that's unintended.
That's great. Thank you. I have to ask, is research like this, is treatment like this available in other countries? Is it happening in other countries? We actually have a lot of Canadian participants, and some of them are curious.
Yes, these experiments at least are being engaged sort of worldwide. The
Okay.
Europeans oftentimes lead in many things. I think the US is leading a lot here. Unfortunately or fortunately, that's driven largely by the pharma sort of investment in this. I am aware that the Canadians, for example, have a couple of centers throughout Canada that really lead in bone marrow transplant, but there is a dearth of, I think, these kinds of experimental trials using CAR T cells. Keep keep your sort of radar up, stay tuned. I am aware, for example, the University of British Columbia has a large investment in cellular therapy that would include CAR T cell trials and then implementation of the approved type of cellular therapy eventually. So I just think that that's not something I would be shy about asking any of your doctors in Canada. This is there just as much, the attention is there just as much as it is here.
And then, for folks here in the US as well, is there a best way to look for these trials and experiments that are occurring? Do you have any recommendations for how to find them?
Well, first and foremost, I would ask your doctor. If you're seeing a neurologist, hopefully they have experience in MS. If they're an MS trained neurologist, that's even better. They would have a lot more familiarity with this. Um, I would also point out that the slide I mentioned, the 4 different examples of clinical trials, comes from a website called clinicaltrials.gov. Anyone has access to that. You don't have to be a researcher. You can look very specifically in the search window for CAR T cells and multiple sclerosis, and it'll show you anything that's either enrolling or has finished enrollment around the country, or actually anything that's registered with the US government, which doesn't have to be a US trial, for example. I would seek those types of resources to answer that question.
Yeah, that's great. We always recommend talking to your doctor, so I definitely will echo that again. That's always a great place to start. So what is the expected outcome for this treatment?
Great question. Ideally, a therapy used like this would halt progression. I think what we really are aiming for is continued control of relapses, which of course this therapy would be very good at as well. But really the optimal, ideal situation on one level would be complete control of progression, stability. Even more impressive, I think, would be the idea that we could use CAR T cells eventually to improve function. That's almost something that's heretical in saying amongst the scientists or clinicians, but that's the goal. And I know that's the goal for many, many patients. That's my goal when I see patients. If we could get some therapy to take a person with disability and improve their function, that would be fantastic. And I'll just mention real quickly something that sounds a little bit like science fiction, but really is not that far off because of the flexibility in our CAR designs, that as a living drug, CAR T cells don't necessarily have to be killers. The chimeric aspect here is recognition and signaling. To date, all I've mentioned is the fact that that signaling leads to effector functions the T cell kills. Imagine a situation in which now, with very selective recognition, that T cell is a payload deliverer of something that could help remyelinate or repair a nerve or regenerate something. We are now imagining the CAR T cell as essentially a payload delivery. And that would be super cool. For example, if it went into the meninges or went to the brain, because that's what immune cells do in MS, and then started to do something really beneficial in that aspect of the disease. It isn't something that's been developed enough for clinical trials. And I say that only to elicit a lot of imagination from our listeners, because the sky's the limit with CAR T cells. I think that's one of the attractive features here. It's always been something that we could sort of imagine to harness because, again, the engineering of it is so simplistic, really, and flexible.
This feels very hopeful, and I can sense your excitement about it. So is this kind of the stepping stone, a step in the cog to an eventual potential cure for MS, do you think?
Oh, I've
I
really
know.
look, I know that there's only one other group of people that want that more than me, and that's those living with MS or affected by MS. I'm affected by MS as a clinician. I want to cure MS. Don't want to go so far as to sound so boastful or egotistical. I've been burned with lots of different things in the past. But let me say this for the record. I think it's very important to have that ambition. We should expect that. Now, would CAR T cells be the cure? I don't know. I'd like to imagine that, as I said before, when we do a reverse engineering with CAR T cells, it leads us to the next level of therapy that could eventually, ultimately lead us to a cure. I'm not opposed to that at all. I'm just very wary that I don't want to set that false of an expectation from this.
Well, thank you. I appreciate that. So for these treatments, would you be allowed to stay on a DMT? Would you want to do that? If that was an option, I'd love to know more on the potential interaction, if that is even a thing.
Sure. I think it depends on lots of different things. Number one, which disease modifying therapy you're currently on. As I alluded to, or actually indicated, showed in the slide, is that one way in which CAR T cells are delivered to a patient is to condition them before they receive the final treatment. That is to say, we actually use very potent immunosuppressive drugs to clear space so that these CAR T cells can be transferred into an individual. Because of that, we do worry that in addition to the current disease modifying therapies, someone could end up being too immunosuppressed and have their immune system shut down too severely. So at the moment, these CAR T cells would be used in isolation.
Okay.
That being said, who knows? We don't know yet. We just don't know.
Yeah, there's a lot to learn. How long will the effects of the treatment last for individuals?
Right. So we don't have a good handle on that from large scale data. The two cases that I showed, for example, the first one, I believe the patient number one who was on the top part of those graphs, those analyses, or at least the report went out for a few months. The second patient's, disease course and sort of characterization was even shorter. It was about a month. There is no question, though, because of the way in which the data from those two individuals demonstrated the persistence of CAR T cells and reduction of inflammatory changes, that that effect should last much, much longer than what was reported. A typical MS trial is about 2 years. We assess a treatment effect in relapses, unfortunately. That was kind of the main goal of many of the trials. A 2 year time frame may not be actually ideal for a progressive trial. But the reality is, if we can see a durable benefit for 2 years and then extend that window in a trial for an extension, for example, for another 1 or 2 years, to me, that's only feeding the idea that the durability of the CAR T cells could be much, much longer than that. The expectation is really that these CAR T cells will do their job indefinitely. They've integrated into our immune response so that we don't have to take any more therapies.
Wow, that's amazing. I love to hear that. Um, so another question that I have, a lot of times we talk about MS as the snowflake disease. It's very unique to each individual. Is CAR T therapy something that can be personalized to that level to address individuals' needs with MS since it's such a different disease for everyone.
Yes, and I do agree that that's probably a huge priority, along with the idea that progressive MS is being undertreated. The real personalization, almost in a fantastical way, would be to get some particular signature and predict how your disease will unfold, and then use CARs or other types of therapies that specifically interfere with those steps that will eventually play out. In CAR T cells, I think the design right now isn't so much personalization. But as I said earlier, I think that there's a lot of flexibility and possibility for manipulation so that this could be personalized. Using the example that I gave from my own research, in which we can selectively interfere with only some T or B cells, I think what would be personalized in that regard is, just like you said, a snowflake disease. One individual comes to the clinic, we say, these are your bad immune cells. These are the set of specificities that we need to remove. And that's going to be different from the next patient that walks in, and we could identify those. And by the way, the only reason for identifying those sets of autoreactive T and B cells would be to eliminate only those. And CAR T cells have the potential to do that.
Wow. Um, what's the timeline for potentially all the stages of this research and potentially having access to a treatment realistically?
Realistically, I would say probably 4 or 5 years, but
Okay.
I am not the person to answer that. I would turn to someone much more, I think, directly involved, whether at a pharmaceutical company or is more directly involved in clinical trial design. To me, my awareness is that we're just entering phase 3. The phase 3 trials can take 3, 4 years. FDA approval can take longer beyond that. But if we really do accelerate this, it may be for 4 years, 3, 4, or 5 years that we start to employ this regularly. Oh,
Okay.
and I'd like to point out too that just like I was mentioning, there's autologous and off the shelf. Turns out that there are multiple companies trying to develop CAR T cells that distinguish themselves. How do they distinguish one company's CAR from another besides being autologous or off the shelf? Well, it's how well they signal or what the recognition targeting receptor domain may be. And those, I think, are really great examples of the idea that we need a vanguard. We need something to kind of open up the possibility of CAR T cells. Once that's done, I think the sky's the limit in terms of how many other trials will eventually be done, how we can iterate the effectiveness of these CAR designs so that a winner emerges to say this is superior. So even if it does emerge onto the scene and is FDA approved or available for routine clinical care, I think we're going to be stepping into an era where that continues to unfold. And it's not the first is the only thing that we have or first is best. It may be that it's only the beginning once that's approved.
Okay. Well, thank you so much. We have just 2 minutes left. Is there anything else that you wanted to mention or comment on before I thank everyone?
No, I'm hoping that I was clear. I know sometimes this can be really difficult and complex. I'd like to thank everybody for their attendance. This has been exciting for me, and I really do hope that you can tell that I'm optimistic and that this is something that would be helpful for many, many people. So thank you very much.
I think it does bring a lot of hope, and I sense your excitement and your optimism around this treatment. So I hope that our participants do too. Dr. Wu also joined us on our Can Do MS podcast this week. The episode released earlier this week, so definitely check that out. I think, again, there's just a lot of hope for this type of treatment and innovation. So thank you very much, Dr. Wu, for all of the research that you're doing and work that you're doing out there in the world for the MS community. I really thank you for that. Thank you to our participants for being here tonight. We really appreciate you showing up. I'm absolutely amazed by the turnout, so thanks for joining us. And lastly, I will also say thank you to our sponsors once again for the support of this program and making tonight possible so we can provide this information to you.